You know, you probably have a box of Imodium sitting in your bathroom cabinet right now.
Oh, almost certainly. Everyone does.
Right. It's totally mundane. It's just boring. But what if I told you that this cheap over-the-counter stomach pill is actually a highly potent opioid?
Yeah, it really is.
And like the only reason you aren't experiencing a massive euphoric high right now is because of this microscopic bouncer stationed inside your brain, just physically throwing the drug back out into your bloodstream.
I mean, it is one of the wildest biological workarounds in modern pharmacology.
It's crazy.
We really do just think of these medications as simple plumbing fixes,
Yeah.
But the cellular mechanisms actually keeping them safe are incredibly complex.
Which is exactly why we are diving into this today. We've got a fascinating stack of sources in front of us today. Pharmacology notes, some historical case studies, and these pretty intense medical reviews on a drug class known as antidiarrheals.
Yeah, quite a stack.
And our mission for this deep dive is to basically figure out how these drugs actually slow the gut down. But looking at these notes, the very first thing that jumps out to me is that the word antidiarrheal is basically a lie.
Completely.
Because when you reach for, say, a beta blocker, you know it blocks beta receptors, right?
Exactly.
The name tells you exactly how it works. But antidiarrheal just tells you what you desperately hope the outcome is.
Yeah, it is a purely functional label.
Mm-hmm.
It is completely divorced from the actual mechanism. I mean, it doesn't tell you anything about what the chemical is doing to your cells.
Okay, let's unpack this. Because going through the research, this whole category feels less like a specific medical discipline and more like the pharmacological equivalent of the junk drawer in your kitchen.
Oh, that's a great analogy.
Right. You open it up and there's a rusty screwdriver, there's some duct tape, a bottle of super glue, maybe a bent paperclip. The only thing unifying those items is that when something in your house suddenly breaks, you frantically reach into that drawer for a quick fix.
Yeah.
But duct tape and super glue, I mean, they do not solve problems the same way at all.
No, they don't.
Yeah.
In medicine, we see at least 4 completely distinct mechanisms lumped into this one antidiarrheal drawer.
4 of them.
Yeah, at least 4. You have drugs that paralyze your intestinal muscles. You have drugs that alter the osmotic balance to stop fluid secretion.
Oh.
You have compounds that just soak up bacterial toxins like a sponge. And you even have these synthetic hormones that treat complex endocrine tumors.
Wow.
Right. And none of them work the same way at a cellular level.
So to understand why this drug class is such a wild grab bag, we have to go back to the origin of the most famous tools in that drawer.
Right.
And I was reading the case history here, and I'm honestly a bit confused. Because the modern story starts in 1953 with this 27-year-old Belgian pharmacologist named Paul Janssen.
Yes, Janssen.
And he's tinkering with an opioid chemical scaffold called meperidine. Basically, he is trying to invent a better painkiller.
That was the goal, yeah.
But instead of throwing away the failed drugs that didn't work on the brain, he pivots to the gut. Why? Like, what made him think a failed painkiller would cure dysentery?
Well, to understand Janssen's pivot, you have to look at what opioids actually do to the human body as a side effect.
Okay.
For thousands of years, I mean, going all the way back to raw opium use, a universal side effect has been severe constipation.
Oh, right, of course.
Yeah, so Janssen's team noticed that some of their new synthetic compounds were failing as painkillers because they barely crossed into the brain at all.
So no pain relief.
Exactly. But when he observed the test subjects, their intestinal motility, the wave-like muscle contractions called peristalsis, that motility aggressively slowed down.
Here's where it gets really interesting, because you'd assume he was on some, I don't know, noble crusade to cure global diarrheal disease.
You would think so.
But no, this was pure medicinal chemistry curiosity. They were just trying to isolate the side effects of opioids from the pain-relieving effect.
Just tinkering in the lab.
Right. Antidiarrheals were basically a side door out of their painkiller research.
A very lucrative side door, as it turned out. Because by 1956, Janssen's team synthesized a compound called diphenoxylate.
Diphenoxylate.
Yes.
Yeah.
And it hit the market in 1960 under the brand name Lometil. But there was a massive hurdle they had to clear first.
Because of the opioid connection?
Exactly.
Yeah.
Because diphenoxylate is structurally an opioid, there was a huge risk that people would just take massive handfuls of it or crush it up and inject it.
Just to force enough of it into their brain to get high?
Exactly.
So how did they stop that? Because, I mean, Lometil is still prescribed today.
Well, Janssen's team did something incredibly clever. They paired the diphenoxylate with a subtherapeutic dose of a completely different drug called atropine.
Atropine.
Yeah, and atropine actually comes from the deadly nightshade plant.
Wait, they put nightshade in a stomach pill?
They did.
Does that help with the digestion or something?
No, it does absolutely nothing for the diarrhea at that dose. The atropine was put there strictly as a punishment mechanism.
A punishment mechanism.
Yeah, it was an early, ingenious form of an abuse deterrent.
Oh, I see.
So if you take the normal prescribed dose of Lomotil,
Yeah.
you don't even notice the atropine. Your symptom stops, and you just go about your day.
Okay.
But if you try to take 10 times the dose to chase an opioid high, that extra atropine scales up and triggers severe anticholinergic toxicity.
Meaning your body's rest and digest system gets completely blocked.
Completely blocked.
The notes describe it as feeling like you've literally been poisoned, like severe dry mouth, a racing heartbeat, blurred vision, you can't urinate.
It's awful.
It basically makes you so physically miserable that you would never want to abuse the drug ever again.
Right. It set a brilliant template for drug safety. But, Janssen kept refining the chemistry. He actually wanted a drug that didn't even need the atropine punishment.
Okay, so something inherently safer.
Exactly.
Yeah.
So in 1969, his team synthesized a much more selective molecule, loperamide.
Which most of us know as Imodium.
Yes, Imodium.
It got U.S. approval in 1976 and then became available over the counter by 1988. I mean, it is arguably the most famous drug in this space.
Without a doubt.
But if it's an opioid, how on earth is it just sitting next to the toothpaste at my local pharmacy?
Well, what's fascinating here is how loperamide leverages the anatomy of your nervous system. You really have to look at the gut's second brain.
The enteric nervous system.
Exactly, the enteric nervous system. You have this massive mess-like network of millions of neurons embedded right in the lining of your intestinal tract.
Yeah.
And those neurons are absolutely covered in mu-opioid receptors.
The exact same receptors that morphine targets in the brain and spinal cord.
Yes, just located way down in the gut.
Okay, so what happens when you take it?
When you swallow loperamide, it binds tightly to those mu-opioid receptors in the gut wall. And this binding suppresses the release of acetylcholine.
Acetylcholine, right.
Right, which is essentially the chemical spark plug that tells your intestinal muscles to contract.
So no spark plug, no contraction.
Exactly. When you drop those levels, the rhythmic squeezing contractions of your gut just grind to a halt.
So by freezing the plumbing, essentially the stool just sits in the colon much longer.
Precisely.
And since the colon's primary job is to extract water from waste, the longer the stool sits there, the more water gets pulled out of it.
Right. It turns a loose, watery emergency into something firm.
I actually saw a 2007 Cochrane review in our sources showing that loperamide cuts the duration of diarrhea by a full 24 hours.
It is highly effective.
But that still doesn't explain why it doesn't cross into the brain and make us high.
Well, that brings us back to the microscopic bouncer you mentioned earlier.
The bouncer, right.
Yes. The blood-brain barrier is lined with this specialized protein called an efflux pump, specifically one called P-glycoprotein, or PGP.
PGP, got it.
Think of PGP as a highly aggressive security guard. Loperamide is highly lipophilic, meaning it can easily dissolve through cell membranes.
So it wants to get in.
Oh, it does. It
Yeah.
technically does breach the blood-brain barrier.
Wait, it actually gets past the velvet rope.
It does. But the second it gets inside, the PGT pump physically grabs the loperamide molecule and actively ejects it right back into the bloodstream.
That is incredible.
It pumps it out almost as fast as it gets in.
Mm-hmm.
The drug is never allowed to accumulate in the brain tissue long enough to trigger any kind of euphoria or slow your breathing.
So it is purely a peripheral opioid, operating strictly from the neck down.
Exactly.
That is wild. Our biology is actively filtering the drug in real time.
Every second.
So that's the first tool in the junk drawer, anti-motility agents. They basically paralyze the traffic.
Yes.
But I was thinking about this. If the muscles cramping and moving too fast is only half the problem, what happens if the gut lining is actively pouring water into the intestines?
Right.
Like you can't just freeze the plumbing if the sink is still overflowing, right?
No, you really can't. If we connect this to the bigger picture, diarrhea is mechanically driven by two levers. Either things are moving too fast, or your intestinal cells are actively secreting excessive fluid into the lumen.
So secretory diarrhea.
Exactly. If you have secretory-driven diarrhea, paralyzing the gut muscles with loperamide can cause awful, painful bloating and rebound constipation.
Because you are basically trapping all that excess fluid inside a paralyzed tube.
Yes, it's a terrible feeling.
Which means we need a totally different mechanism. I actually want to look at a drug mentioned in the note called resveratrol.
Resveratrol, yes.
It's apparently widely used in Europe and Latin America, though not so much in the U.S. The notes say it doesn't touch the muscle contractions at all.
It doesn't. Resveratrol approaches the problem by targeting a completely different specific enzyme called enkephalinase.
Enkephalinase.
Right. Your gut naturally produces its own internal opioid-like peptides called enkephalins. These are your body's natural stress and pain relief molecules.
Oh, okay.
And enkephalinase is the enzyme whose sole job is to break those enkephalins down once they've done their job. Resveratrol inhibits that enzyme.
So by stopping the enzyme, you basically allow the body's natural enkephalins to build up in the gut.
Exactly.
But wait, if they are opioids, why don't they just paralyze the gut like loperamide does?
That is a great question. Because there are different flavors of opioid receptors.
Oh, okay.
Loperamide hits the mu-opioid receptors, which we said control muscle contraction. But these natural enkephalins have a high affinity for delta opioid receptors.
And what do delta receptors do?
They regulate fluid exchange. When enkephalins bind to delta receptors on the intestinal cells, it signals those cells to stop pumping chloride and water out into the gut lumen.
Oh, so if loperamide is like throwing a roadblock on the highway to slow down traffic,
Yeah,
resveratrol is like just turning off the water faucet at the source.
that is exactly it.
The traffic keeps moving at a normal, healthy speed, but you stop the flood.
Right, which explains why people don't get that painful bloating with it.
But then there's an even more extreme version of the overflowing sink. The notes highlight this drug called octreotide, which is a synthetic version of the hormone somatostatin.
Yes, octreotide.
And this one really blew my mind because we aren't even talking about a stomach bug anymore.
No, we were talking about endocrine tumors.
Tumors.
Yeah, octreotide is used for patients with rare hormone-secreting tumors, like phegopomas in the pancreas, or certain carcinoid tumors.
Okay.
These tumors basically hijack the body's chemical signaling. They pump out massive amounts of hormones that order the gut to just secrete fluid nonstop.
I mean, the sources mention patients suffering from 20 or more massive watery stools in a single day.
It is incredibly debilitating.
You could give a patient like that buckets of Imodium and it wouldn't make a dent, would it?
It would fail completely.
Because the mechanism is completely different.
Right, because the problem isn't a local bacterial infection. And it isn't an issue with the enteric nervous system's muscle tone at all.
It's the tumor.
The problem is a massive systemic hormonal override coming from that tumor. So octreotide directly mimics somatostatin to suppress the release of those gut hormones.
Wow.
By shutting down the chemical signal at the source, patients can go from 20-plus stools a day back to near normal function.
It really just proves that sometimes an antidiarrheal isn't treating the gut at all. I mean, it's managing complex oncology.
Exactly.
Which brings us back down to earth, I think, to the most common tool in the average household's junk drawer.
The classic pink liquid.
Pepto-Bismol, or bismuth subsalicylate. I always just thought of it as this chalky sludge that coated your stomach, but apparently it's actually doing 3 distinct things at once.
It is. It's a chemical triple threat.
Okay, let's hear them.
First, the salicylate component works very similarly to aspirin. It inhibits prostaglandin synthesis, which mildly reduces the inflammation fluid secretion in the gut.
Kind of soothing it.
Right. Second, the bismuth compound physically binds to bacterial toxins, neutralizing them so they can't irritate the intestinal lining.
So it's literally a sponge.
Exactly. And third, it has direct antimicrobial properties. It actually damages the cell walls of pathogens like E. coli and H. pylori.
So it coats, it neutralizes toxins, and it straight up murders the bacteria.
It does all three.
Which explains why travel medicine clinics absolutely swear by it. I read that taking prophylactic bismuth subsalicylate can cut your chances of getting travelers' diarrhea in half.
It's very effective for that.
But let me ask you this. If it's that effective at killing bacteria and stopping the symptoms, why don't I just drink a bottle of Pepto every morning when I'm on vacation in a high-risk area, like just as a preventative?
Because of toxicity accumulation.
Oh, really?
Yeah, salicylate is absorbed into your bloodstream.
Mm-hmm.
If you drink it like water every day, you risk salicylate toxicity, which manifests as ringing in the ears, tinnitus, or even metabolic acidosis.
Oh, wow.
Furthermore, while bismuth absorption is very low, taking massive amounts over long periods can lead to bismuth's neurotoxicity.
Yikes.
Yeah, it is a fantastic short-term tool, but is definitely not a daily vitamin.
Okay, so we have all these incredible tools to stop the plumbing, dry up the fluid, or kill the bacteria. But I feel like this brings us to the most critical tension in this entire deep dive.
The debate.
Right. Because reading through the medical consensus, the real debate isn't about how to stop the gut. The debate is, Should we be stopping it at all?
And that is the uncomfortable reality of this symptom.
Yeah.
Diarrhea is often an evolutionary clearance mechanism. It is your body's frantic attempt to flush a dangerous pathogen out of your system.
So think about invasive pathogens like Salmonella, Shigella, or Clostridioides difficile, what we call C. diff.
Right, nasty bugs.
These aren't just hovering in the gut fluid, right? They're actively attacking and burrowing into your colon wall, producing toxins.
Exactly.
If you take a muscle-paralyzing drug like loperamide to freeze the plumbing, you are essentially slamming the exit door shut.
You are. You're creating a stagnant, warm pond inside your colon, trapping the bacteria and their necrotizing toxins right up against your vulnerable tissue.
Oh, that sounds terrible.
It allows the infection to burrow deeper, which can lead to a feared catastrophic complication called toxic megacolon.
Toxic megacolon. I mean, just the name sounds like a medical nightmare. What is actually happening to the body when that happens?
Well, the colon rapidly widens. It dilates massively because the trapped inflammation damages the nerve and muscle layers of the intestine.
So it just balloons out.
Yeah, and it stops functioning completely. As it stretches, it loses its blood supply, the tissue becomes necrotic and dies, and eventually the colon can physically tear open or perforate.
Oh my God.
This spills feces and massive amounts of bacteria directly into the abdominal cavity, causing fatal sepsis.
So what does this all mean? It means if you are reading the warning label on a box of Imodium, you have to fundamentally change your calculus.
You really do.
You aren't just checking how many pills you can take.
Yeah.
If the label says do not use if you have bloody stool or a high fever, it is explicitly warning you that using this drug could turn a bad weekend into a ruptured colon. If there's blood or a high fever, the plumbing absolutely needs to stay open to clear the threat.
And you know, this profound realization about clearance mechanisms actually triggered a massive global paradigm shift in pediatric medicine.
Oh, I was reading about this.
Right, because throughout the 1970s and 80s, doctors in the developing world routinely handed out antimotility drugs to young kids suffering from acute gastroenteritis.
It was just the standard reflex to stop the symptom.
Exactly.
But the notes highlight a massive pushback from the World Health Organization and UNICEF. And if you are a parent listening to this right now, pay attention because this changes everything about how we view sick kids.
It really does.
The WHO stepped in and explicitly told doctors to stop giving these drugs to children. Why are kids so much more vulnerable to these drugs than adults?
Because children are not just tiny adults. Their physiology is entirely different. First, their blood-brain barrier isn't always as robust, and they are much more susceptible to the respiratory depression caused by opioid-based drugs like diphenoxylate.
Which means they could literally stop breathing.
Yes, but the mechanical danger in the gut is even more insidious.
How so?
A child has a much larger intestinal surface area relative to their total body volume. If you paralyze a child's gut, you can induce an ileus, which is a complete lack of bowel movement.
Okay.
The child might look like they were getting better because there is no more diarrhea in their diaper.
But they're not?
No. In reality, they are secretly pooling massive amounts of fluid inside their dilated, paralyzed intestines. They're rapidly dehydrating from the inside out, and the drug is masking all the evidence.
That is terrifying. The parent thinks the child is cured, but the child is actually going into hypovolemic shock.
Exactly.
Diarrheal disease remains one of the leading causes of death in children under 5 worldwide. So if the WHO says no antidiarrheal drugs, I mean, what is the frontline treatment?
The true medical miracle of the 20th century isn't a drug that stops the gut. It's oral rehydration therapy, or ORDM. Yes. These are incredibly cheap sachets containing a highly specific ratio of salt and sugar, dissolved in clean water, usually paired with a zinc supplement.
Oh, so like Pedialyte here in the States.
Exactly like that. The exact ratio of sodium and glucose exploits a specific co-transporter in the gut wall that forces the intestines to absorb water, even while the diarrhea is actively flushing out the pathogen.
So it bypasses the problem.
It does. In the eyes of global health experts, antimotility drugs are secondary, optional, and highly dangerous for kids. The actual life-saving medicine is just hydration.
So to all the parents listening who have ever felt guilty for just pushing fluids and Pedialyte instead of giving your kid actual quote-unquote medicine to stop a stomach bug, don't feel guilty.
No, not at all.
The global health data literally says you are doing the exact right thing.
100%.
But this brings us to a surprisingly dark chapter in recent medical history, because dismissing these over-the-counter medications as just harmless stomach soothers for adults has created some fatal misconceptions.
It has.
Let's start with the pink stuff, Pepto-Bismol. People think of it as harmless chalk.
But as we discussed, the subsalicylate part of the molecule metabolizes into a salicylate. That places it in the exact same chemical family as aspirin.
And medical guidelines are fiercely strict that you never, ever give aspirin to a child or teenager who is recovering from a viral illness like the flu or chickenpox.
Never.
Oh.
Because doing so can trigger Ray's syndrome.
Ray's syndrome.
Right. It is a rare but catastrophic condition that causes massive swelling in the liver and the brain, and it can be fatal. Bismuth subsalicylate carries that exact same Ray's syndrome warning.
Wow.
But because the bottle doesn't scream aspirin in giant letters, well-meaning people miss it, just assuming it's a benign syrup.
It's just a pink stomach liquid to them. Also, quick side note for the listeners about Pepto. The bismuth reacts with trace amounts of sulfur in your digestive tract to form bismuth sulfide.
Ah, yes.
Which is completely harmless, but it will turn your tongue and your stool pitch black. So if that happens, do not panic. You are not internally bleeding.
Good to know.
But the second misconception we need to cover is far more dangerous than black stool. It's the assumption that because a drug is sold over the counter, taking a massive handful of it must be relatively safe.
This takes us back to loperamide and the mid-2010s opioid crisis.
Because we established earlier that loperamide is an opioid, but you don't get high because the P-glycoprotein pump, that bouncer in your brain, throws it out.
Right.
Normal dosing is about 2 to 8 milligrams a day. But what happens if you take hundreds of milligrams?
Well, people who are desperate to stave off opioid withdrawal or looking for a cheap high discovered a terrifying workaround they dubbed the poor man's methadone.
The poor man's methadone.
They realized that if you take an extreme, massive dose of loperamide, you can physically overwhelm the PGP pump.
Basically, if you send 400 people to rush the door all at once, the bouncer just gets swarmed and the drug floods across the blood-brain barrier.
Case reports showed patients swallowing anywhere from 70 to over 400 pills at a single time.
400 pills?
Yes. And at those astronomical doses, enough of the drug saturates the central nervous system to produce opioid euphoria and suppress withdrawal.
But there is a fatal catch here.
There is, and this raises an important question about how we evaluate hidden drug toxicities.
Because no one was testing for this, right?
Exactly. Loperamide was considered so perfectly safe that warehouses shipped bulk bottles of 400 pills to every pharmacy. Nobody knew what the drug did at massive abusive doses because nobody had ever tested it that way.
Right.
It turns out, when you take hundreds of pills, the loperamide molecule binds to and blocks a specific potassium channel in your heart muscle called the HERG channel.
Wait, I want to make sure we get this right. Potassium channels are crucial for the electrical reset of the heart, right? Like a camera flash needing to recharge before it can fire again.
That is a brilliant way to visualize it, yeah.
Yeah.
Every time your heart beats, the muscle cells depolarize to contract, and then potassium flows out through these HERG channels to repolarize or recharge for the next beat.
Okay, so a rapid recharge.
Right. If loperamide blocks those exit doors, the heart cell stays electrically charged for too long. On an EKG, we call this QT interval prolongation.
And if the electrical recharge is delayed, I'm guessing the rhythm goes haywire.
It leads to absolute chaos. It triggers life-threatening arrhythmias, specifically a chaotic, undulating heart rhythm called torsades de pointe, which often degrades straight into cardiac arrest.
That is terrifying.
People were trying to hack an over-the-counter stomach pill to get an opioid high, and instead they were triggering fatal heart attacks.
The case reports are just grim. And
Wow.
because of this spike in deaths, the FDA actually had to step in. In January 2018, they mandated that manufacturers severely limit package sizes for over-the-counter loperamide and required the use of blister packs.
Right.
They essentially had to make it physically annoying and time-consuming to individually pop 400 pills out of plastic bubbles just to deter the bulk dosing.
It is a sobering reminder that every drug, no matter how ubiquitous, has a toxic threshold.
It really is. So let's synthesize this journey. We started by opening the pharmacology junk drawer, looking at a label, antidiarrheals, that deceptively only describes a symptom, not a mechanism.
Right.
We explored how a Belgian chemist, Paul Janssen, accidentally built a gut-paralyzing opioid while looking for a painkiller. We saw how different drugs act like roadblocks to stop transit, or shut off cellular faucets to stop fluid, or act as chemical sponges to neutralize toxins.
And crucially, We unpacked the biological reality that diarrhea is a clearance mechanism. We learned the delicate balance of knowing when to use these drugs, avoiding things like toxic megacolon,
Absolutely.
and understanding that for global child mortality, the answer is always hydration, not an anti-motility drug.
Yeah, that is so important. For you listening, whether it's grasping the sheer scale of pediatric dysentery or simply deciding whether you should pack Pepto or Imodium for your next vacation, pharmacology requires looking past the symptom. You have to understand how the tool in your hand actually works on a cellular level.
You really do.
Which leaves us with one final thought to ponder based on these notes. We spent a lot of time talking about loperamide and that tiny, invisible P-glycoprotein pump, that microscopic cellular bouncer protecting the blood-brain barrier.
Yeah, the peachy poop.
If a seemingly mundane, over-the-counter medication only remains safe because that tiny biological bouncer is working tirelessly every second to keep it out of your brain,
Hmm.
it really makes you wonder, what other quote-unquote harmless daily medications are hiding profound, life-altering effects just barely held in check by our body's invisible cellular defenses?
This is a staggering thought.
Thanks for taking this deep dive with us.